Good afternoon. Welcome to What's in Store 2026, What's in Store for Health and Care. I'm joined by my colleagues, Siva and Simon, who we will be hearing from shortly. And I'm Sarah, Chief Exec at the King's Fund. Please submit questions via the Q&A tab at the top of your screen. You can vote for your favourite questions by upvoting them using the upwards arrow next to each question. And we do hope you have the opportunity to visit our resources that were provided in the joining instructions that went out with today's meeting. Hopefully they contain useful information relating to several of the topics that we're going to be talking about today. So we're going to mainly take questions and have a discussion during this session, but we're going to spend the first couple of minutes setting the scene. I'm going to start and then hand over to Simon and then Siva. And the session is really about challenges, opportunities and innovations that will shape health and care over the coming year. So I'm going to make a couple of opening comments. I wrote a blog a few weeks ago on a very similar issue, sort of setting the scene for the coming year. So I'm going to pull out a couple of the points. It felt quite cathartic to write the blog because it's a busy year. There's so much planned ahead. But I am going to start by mentioning something that was published yesterday, and that's the Health Survey for England 2024 data, because I think this is an important point of context. So the survey showed essentially, a mixed picture, but continued challenges for our population's health, particularly around, for example, levels of overweight and obesity and inactivity, and also the proportion of people, over a quarter, living with at least one long-term condition, and that's all adults, all over 16s. So I think in attempting to improve health and care in various ways as a health and social care system, important to remember the backdrop and the population health context that we are working in. So to make a couple of other points by way of introduction, there's a lot going on this year or planned for this year to operationalise the big ticket strategies and plans that were published last year, or the big decisions that were made. So last year, of course, saw publication of the 10-year health plan. We also had a comprehensive spending review and the big decision to bring together NHS England, the Department of Health and Social Care, and also to restructure or change the infrastructure for regional health and care, as well as rather a lot happening to local government. So in one sense, this year is about beginning to operationalise that, and so expect lots of plans, model frameworks, contractual documents, and so on, that seek to bring to life and operationalise particularly elements of the 10-year health plan. That's point one. I'm sure we'll have the opportunity to get into this in more detail. Point two, always important to remember, and I'm sure most people on this call will be working in health and care in some guise. There's plenty that's going to be happening across government, not necessarily directly related to health and social care, that nevertheless will have an impact on health and care. A couple of examples. One, measures to tighten immigration rules, we think will have an impact on an already depleted social care workforce, likely to hit the health workforce as well. Alan Milburn, former health secretary, is also carrying out a review of NEETs, those younger people not in employment or training. I should well imagine that will make some health recommendations, even though it's a broader scope, when that publishes. So watch out for what else is happening across government. Point three then, this is something the King's Fund thinks about and talks about a lot, and that's public satisfaction with our health and social care system. We will, with our friends at the Nuffield Trust, publish updated public satisfaction outputs, results, in a couple of months' time, but we'll be keeping a really close eye on, is everything the government is trying to do to improve health and care making a difference? Is it feeling real out there in the world? We're beginning to see ever so slight upticks in confidence or satisfaction in the latest GP surveys and the latest maternity survey, so that's going to be really interesting to watch. And then I just wanted to mention that we do expect new primary legislation, a new health bill, probably introduced in Parliament in April. We need that, or rather the government needs that, to formally abolish NHS England and do other things that it has said it will do, like abolish national and local health watch, give trusts and FTs additional powers, and so on. So that's going to be big in Parliament, because that does give parliamentarians the opportunity to scrutinise health policy. I think the big risk, and again, we may get into this in more detail, is a dissonance between what the government is saying, which is we want to empower patients, we want to devolve lots of day-to-day health and care responsibility to regions and localities. We recognise we can't run everything from Whitehall, with what the bill actually does, because if the bill is, for example, abolishing Health Watch, does that send the right message about the importance of hearing from and empowering patients? Final word, and then I'm going to hand over to Simon, is social care. So Casey, Baroness Casey, who is leading a review of social care, is due to publish her first output this year, and hot off the press, we've heard just in the last 12 hours or so that that's likely to be in March. This is going to be very welcomed because we know our social care system is under huge strain, and Casey has a brief to make shorter term recommendations on how to drive improvement, but also longer term recommendations about how you might fundamentally fix what we often refer to alongside others as a slightly broken social care system creaking at the seams. So my summary is a lot happening this year, but lots of work to operationalise big announcements that were made last year. Simon.
Thanks, Sarah. Afternoon, everyone. Yeah, interesting opening remarks. I think I'll just say a little bit about me, so you have some context about the perspective I'll be speaking from this afternoon. So I'm a senior consultant in the leadership and organisation development team here at the fund. So that's the arm of the organisation that works out into the system with leaders and managers and colleagues in health and care at all levels. So I'll speak from that perspective. Before I was that, I was a charity chief exec for nearly 10 years. And I've also worked in places like infant mental health teams, community mental health in the NHS and local government. So I'll try and draw on some of those experiences over the last 20 years to put them in the kind of contemporary context. But my opening reflections, I suppose, are just, one of the great privileges of a role like mine is that you do get to be alongside folk in the day job on the shop floor of health and care. And I think one of the overriding conclusions you come to when you spend enough time with them across the system and across sectors, actually, not just into the NHS, is 2026, as it was in 25 and 24, a time of a lot of uncertainty. Uncertainty creates anxiety. Anxiety is tiring. The day job is tiring. And so there's a lot of fatigue, much of it chronic. And in a year where we're going to get a workforce plan to help operationalise the 10-year plan and the strategy for the health and care system, it will be interesting to see the effect and impact that a plan can have on some of those very real everyday conditions across health and care. That said, there's also something else that always strikes me when I was asked to sort of come and offer my thoughts on the year ahead, is that despite the backdrop being pretty testing, and despite the uncertainty that I described and the anxiety, which are very real, and I don't want to diminish those, there is also like a workforce that wakes up every morning and very quietly just goes about the business of caregiving and operationalizing the services that we all kind of rely on. And in that kind of quiet, hidden dynamic is a lot to be hopeful about, and I'm also very lucky that I get to bump into some of that. So although it can feel bleak, I think 2026 is also a time where we might look to some of the stuff that's hidden in plain sight in the workforce and draw some hope and resources from that. And I'll stop there, I think.
Thank you. Well said. Siva.
Thanks, Sarah. Hi, everyone. So my name is Siva. I work in the Policy Events and Partnerships team here at the Fund. And looking ahead to 2026, I think there are four things in my head. One is just the inherent unpredictability of health and care policy. So this time last year, I definitely wasn't telling people, look, NHS England is going to be merged into the Department of Health and Social Care, and there'll be swingeing cuts to ICBs. Didn't see that one coming. So I think there is all predictability. So that's one thing. But the second thing is, it feels strangely like there's probably more medium-term certainty than at any other point I can remember in the last 5 years. And I say that because the 10-year plan, health plan's been published. So you've got your long-term strategic direction for the health service. You've got a comprehensive spending review, as Sarah mentioned. So you've got your funding envelope, you know how much money you have to work with. And over the next few months, we'll have Baroness Casey's first report into adult social care reform and the refreshed NHS long-term workforce plan. So you can see the little bits of the picture being coloured in to give the sector some medium-term certainty. So I'm more optimistic than I normally would have been at this point in the year. The final 2 points from me are, but it is still a bit of a policy stew at the moment. And I use that analogy because I'm going to be doing the cooking at home for the next 4 nights. And I have a very typical approach of cooking, which is I put everything in. You know, there is no herb left untouched. And when I think about policy, particularly NHS policy at the moment, it feels a little bit like that, because the government, 2 years ago, would have said its priorities are things like reducing the gap in healthy life expectancy. They get added to things like we're going to meet standard, we're going to balance the books, we're going to start meeting all waiting time standards. So it feels a little bit like after a period of refining down what the strategic priorities are for the healthcare system, they're suddenly starting to expand again. So I think over 2026, resolving the stew is going to be a big. And the final point I want to end on is I just think, and it might be just an echo chamber issue, but I was listening to a few podcasts recently, and there was an advert for a bank. And part of the sell for, I don't know if you're going to be a premium customer of this bank, is you get better access to healthcare. A few friends of mine who are going for job interviews are asking questions like, is private health insurance included? You know, the wellness industry, this idea of where we get our health information from and who supplies our health, I think is going to look really fundamentally different in the next decade. And I think this could be one of the years where we really start to notice it. So those are some of the things on my head as we enter the year, Sarah.
Thank you. And interesting, you raise wellness and private sector and where people kind of get their health information, because that's already I can see sort of questions coming in that speak to that. Thank you all. Let's go straight to the questions. Some fantastic questions already coming in. I'm going to go to a very popular one first up. Do you think the culling or merging of ICBs will increase or reduce inequalities, i.e. access to care, genomics, that is equitable rather than what's affordable for that region? Siva, do you want to give us a view on what's likely to happen as a consequence of ICB mergers?
Thanks, Sarah. So a few quick points. One, and I know this is going to sound like a cheap shot, but we don't know. Nobody knows. And I find this a bit frustrating because anytime you're making this sort of massive policy change, what would normally happen is you would do an impact assessment where you try and really understand in detail what are the consequences of the choices you're making to reduce the size and number of something like an integrated care board. So I think it is really a fundamental point that we should know, and we don't know because either the work hasn't been done or the work has been done and not shared. Having said that, I think it's a really good question. It raises two things. Number one, there is an upside of having fewer commissioners. You know, when I started my career, there was something like just over 300 primary care trusts or local commissioners. Now we're going to be under 30, so 26. So there is an opportunity for your our experience as patients and members of the public, whether it's something like access to IVF cycles or whatever it is, where there's currently local variation, you might see that variation shrink because we've got fewer different units. But overall, I still think it's so hard to say because so much of these commissioning decisions are still going to have to be made locally. I just cannot see a world in which we have 26 different parts of the country that have the final say on things like how resources are allocated, what services are provided. So I think we're going to end up with something that maybe it'll be called place-based partnerships, locality areas, but something that sits beneath the 26 integrated care boards. And I suspect that in at least some parts of the country, you will still have some differences in approach and what services are offered at that level. But overall, great question. The problem is nobody knows.
Exactly that. I mean, I'd add a couple of points. One is just, of course, the disruption caused by any large-scale reorganisation of this nature. And Simon, you might want to comment on this in a minute, how it's feeling out there on the ground. Often distracts. I've been talking to ICB chief execs and chairs who say, they can't move as quickly as they might like to, or until recently they couldn't with restructure and reorganisation. And just naturally, any big change is disrupting to day-to-day business. I also think, there's a tension here between different ideologies of where you best make decisions and how you drive change efficiently. So on the one hand, you've got a pull to merge and, drive more efficient activity and decision making across fewer footprints. On the other, and you often hear the Secretary of State talking about this, there is recognition that if you are to drive change, real change that sticks to health and care and really grapple with things like frailty, health and care integration and managing long-term conditions, you do need to do that at place. You've got to do that with neighbourhoods. We might come on to neighbourhood health. But so I think there is something to watch through the ICB mergers about exactly how that tension is or how it plays out over the course of the year. Simon, when you're out there speaking to people or you're engaging with people on one of our learning platforms, Shiftworks, are you picking up much about what it feels like, for example, to be in an ICB at the moment?
Uncertain. I think that's fair to say. I was interested in something Siva said you in your opening sort of preamble there about it feels clearer. There's more certainty because we have a plan. And I think it's also true that for those directly affected by the issues facing ICBs, for example, they will feel uncertain. But there's also a truth, I think, that sometimes these plans, they don't cut through to the shop floor. That there's a level at which work just turns over every day, and people feel very, very distant, I guess, from some of these strategies and plans. And I feel a little bit like, having been in the system one way or another for 2 decades, that we tend to meet any challenge in health and care with a reorganisation of some sort, and we tend to do that as though it were an engineering project, rather than trying to intervene in a hugely complex system, which is full of unintended consequences from previous efforts to reorganise it. So just to echo the point about no one would know, and even if we had done the due diligence and the equalities impact assessments, they would still, I think, be best guesses about what the impact might be.
Yeah, thank you. I'm going to stick with this theme. There's a very good question around strategic commissioning, which in a way follows quite nicely. So we hear lots of mentions of strategic commissioning, which to me seems at the moment to be people just putting the word strategic in front of the word commissioning. Any thoughts on what the expectations are as to how commissioning materially changes to become strategic commissioning? Siva.
I've got to admit, personally, I'm with the person who asked the question. What partly because I know this is sort of technocratic babble, but what is commissioning if it isn't strategic? I mean, you can have really operational commissioning, which is who's going to receive that service and who isn't. Every single commission I've ever spoken to in my entire career has been more strategic than operational. So I think there's a little bit of how do we make this sound different in that. So, but leaving that cynicism aside, if I think about the big changes that the health and care system is going to try and do, say these 3 shifts, every single one of them will require the fundamentals of what we used to call, 20 years ago, world-class commissioning. Do you really understand the needs of your population? Are you using and linking data sets to get a really rounded sense of what people need? Do you have really good feedback mechanisms to tell you what more quantitative data can? And then are you making good decisions based on that and involving people meaningfully in those decisions and making clear choices over how you spend the resources that are given to you? So I think fundamentally, the task of a good commissioner now is very, very similar to what a good commissioner would have been doing before, but your sort of portfolio is going to change. Absolutely, 10 years ago, you might not have been expected to do as much of specialized commissioning. Now you will be. So your portfolio will be changed. But as a skill set, as a function, as a need in our healthcare system, I don't think that's going to change, whether you call it strategic commissioning or not.
Thank you. Yeah, and I've heard quite a lot of people talking about the need to ensure we've got enough great commissioners in the system, exactly for the reason you cite, Siva, because to do some of the changes that the 10-year plan and other documents suggest we will do. I mean, it sort of leads you into the workforce plan. What are we valuing in our workforce for the next few years? How are we ensuring that we invest in leadership and skills? And how do we make sure that in a period of huge organisational disruption, transition, we retain the skills and the right mix of skills in our health and care system that we need? So can we spend a minute on the workforce plan? Because this didn't come up really in intro remarks. We know the government is working and officials are working on a new workforce plan. We also know some of the, I suppose, fundamental assumptions are being challenged from the previous plan to the one that's in development. To simplify, we can't just hire an unending number of health and care staff. And so there's an interesting conversation, tension maybe, how much will productivity, that other productivity that staff won't deliver, drive in our health and care system, and what's the role of technology? And there are a few questions coming in on AI and digital. So Siva, you're pretty close to this workforce plan as it develops. And Simon, I know you will have a view on, particularly from I suppose, a sort of people first and working with lots of health and care staff. Either what would you like the workforce plan to make sure it addresses, or anything you're slightly worried and challenged about? And I think, you could put kind of commissioning in that box. If we're saying as a system we need to value commissioners, what will the workforce plan and other similar documents do to aid that? Simon.
Gosh, that's a big question. So I'm going to park my traditional skepticism of plans, but I think the thing that it's hard not to conclude from any plan, particularly one which has got an emphasis on skills and a number of bodies in the health and care system doing work, is that that will only get you so far in sort of meeting some of the challenges in the system. The work that we do out there is almost always focused on the quality of the relationships in the system. And while the skills that people have and the number of people on a shift are really important in terms of determining outcomes, the thing that I would like to see more emphasis on or more discussion about is how we improve the quality of workplace relationships, because there's an awful lot of waste, human waste actually, that gets kind of created by poor leadership, poor management, cultures which are full of incivility, and relationships which contribute to the fatigue that I mentioned in my kind of early kind of intro. So I'd like an emphasis on quality, but the thing is, what can a plan really speak to that? I'm not sure. Obviously, there's a management framework that's going to come down the road. That's going to kind of try to codify some of the behaviours and the skills that we'd like to see in the workforce. But I just come back to this thing that I've seen so many of these plans and so many of these strategies, and they don't touch the substance of the issue in the workplace. So I'm not sure what the answer to that is and how much we should invest in a plan, but it would be nice if the plan, signaled some intention around the value of the quality of relationships, not just the skills and the number of people.
Yeah, really good point. And of course, we have done a lot of work at the fund over the years on culture, the importance of great relationships, the importance of investing in people to develop rounded skills as well as technical skills. Siva.
Thanks, Sarah. Yeah, a few things from me on the plan, and I like this idea of what do I want from it. The first thing is I really do think it's good that we have a long-term workforce plan. When I get outside my bubble, people who run the university courses that train the clinicians of the future and the managers of the future say, look, don't underestimate how useful it is for us to be able to have a document or a set of assumptions to plan around. So good that we're getting one. What do I want from it? One thing is a really clear sense of how what the plan includes speaks to the model of care you want in the future. So everything you were talking about, if we're going to need more strategic commissioners, if you're going to need more data analysts to make sense of population health data, that should be written through the plan. So a very clear path to the future. The second thing is, even if you can't do it this time round, at least a sense of how you're going to think more broadly about the health and care sector, because I understand for very sensible reasons, it largely does feel like an NHS workforce plan. But if you're thinking about the people that contribute to our health, pharmacist trainees, you name it, that goes beyond quite a narrow ambit of pure NHS. I'd like to see some sense of breadth. How are we training the professions we need for a healthcare system of the future? The final two things are, one, honesty, because the book on the previous, or at least my take on the previous workforce plan, was that it was probably too optimistic, on its productivity assumptions. So I think for it to be credible, there has to be either the honesty of here's the weight of the evidence that makes us think we don't need as many as many workers as we were previously projecting, or the honesty to say we just can't afford it as a country. So that's a really difficult choice, and here's the implication for health. And the final thing then is back to Simon's point of some clear message to local employers of we're doing our bit nationally to develop a national workforce plan so universities can train and all the rest of it. Your local employers, you're the people who hold the contracts and who the staff are working with. So a real sense of, over to you now to be a great employer. And just seeing different bits of the government agenda connecting up. We've had Sir Charlie Mayfield's review of good work. We've got things like the health and growth accelerators, which are schemes to try and keep people in employment and from falling out of employment. The NHS is still the single biggest employer in the country. How powerful to be an exemplar of it being a great place to work rather than what we all too often see in the staff survey, which is we can sometimes fall short.
Yeah, thank you. That's incredibly helpful. And I would just stress 2 points. I was chatting a week or so ago to someone very heavily involved in writing the previous workforce plan. He was reflecting your first point, Siva. Look, don't underestimate the value of having a long-term workforce plan. And that's something that people had long argued for. It's a useful discipline to have. It sends a signal. Recognizing your point, Simon, that any plan will only get you so far. And the second point is around the honesty. And it doesn't surprise you that there might be a slight bias towards being a bit too ambitious or baking in productivity targets that maybe haven't been stress tested as hard as they could be. So that's certainly something the fund will be watching for. What are the underlying assumptions that sit behind the headline figures and proposals. I'm going to keep going if I can, because there's some really fantastic questions coming in and want to get through as many as possible. So slight change of tack. With reform taking control of some county councils and possibly winning control of more local authorities in the next local elections, what impact could this have on health and social care in neighbourhoods? I have a view on this, but Simon, Siva, anything you would like to come in on?
I think,
Siva?
sorry.
No, you go.
Yeah, so I think a few things. One will be that, obviously there's the direct impact, which is once you're in charge of particularly adult social care budgets, you are in charge, you are accountable for those decisions. Um, it's a small sample, so I don't want to overstate it, but I think certainly some of the reports have been there is a difference between what you say during a campaign and then when you are the budget holder and accountable for that service. And I think some of the things that are, whatever your political ideology is, they are just truisms of the state of adult social care and the NHS in this country that you start grappling with that reality. So that's one thing they will have, whoever is elected, a direct impact on services, but I think it's still too hard to predict what that direct impact will be. I think the second thing, though, is these local elections are going to have an indirect impact because every other political party is going to be reacting to whoever is successful. And you can react in one of two ways. You can either try and move close towards the policies of that successful party or move away. And again, it's so hard to see at this point in time whether you get a rebounding away. If you get a successful party that is, for example, interested in alternative models for how you fund healthcare, do you really lean into that or do you try and rebound away from it? So I think I don't know how helpful an answer it is, but I think quite quickly within weeks and months, you start to understand what the direct impact is on the people receiving those services in that council. I think it's the indirect, more diffuse impact that is going to be harder to see immediately. That's more between now and the next general election.
Thank you. Simon?
I can't be as eloquent as Siva's just been. So my feeling is a slightly more emotional one in some sense, because I think whatever energy politically you can whip up rhetorically in a campaign, as Siva said, the reality of having to deliver local services is going to throw up all kinds of potential trade-offs for any political party. The interesting thing I think will be what happens when the energy comes out of this particular manifesto. What lies beyond that for politics and where the tolerance that the public have, and for alternative care models. And I was thinking as you were talking, Siva, about this question of honesty and how honest our public life and our politics is about some of the challenges facing the health and care system and the role of citizens too in creating some of those challenges. So I wonder what lies beyond reform in some ways, and when we've kind of tested all ends of the political spectrum and come up wanting for answers to some of these challenges.
I think that's a really good point about how honest any of our politicians feel they can be about some of the longer term challenges for health and social care, or some of the big decisions ahead of us that will either mean changes to services or the need for potentially more money into a system. But I want to add something else, which is I spent some time with some public workers, including some directors of public health, working in reform-led councils last week, and it was a fascinating conversation. And actually, they were reflecting some of what you've said. Of course, it's very different campaigning ahead of an election, in any sort of election, to then having to govern, and you do start often making different decisions and behaving in a slightly different way. They also reflected, I mean, it was different in different places depending where in the country they are, but that actually some of them were having really a lot of traction with reform councillors on health and care issues, but often it really depended on the framing. So they were talking about reform councillors being really interested in uber local activity because there is this sense amongst quite a lot of people voting reform that they feel left behind or that the system isn't working for them. They cited interest in tackling poverty from reform-led councillors because, again, quite a bit of their support is coming from people who may be really struggling with cost of living, and that's very high on their agenda. And they also talked about framing around children and families. I mean, often, this was in the context of public health measures, and often a framing around, this is good for children, adults can get on and behave how they like, but the reason we're taking policy action or we're changing a system is to protect our children. Tends to work with politicians of lots of different colours and persuasions, but they were saying at local level, that's an argument that was having a lot of traction. They were also reflecting honestly that, you know, some of the environments feel really tough, and, you know, there was emotion there in terms of having to upskill and work with a new set of politicians. The thing that we might want to reflect on is, of course, the polls and what might happen in the May local elections and beyond. And, you know, anyone keeping a relatively close eye on the polls might suggest that there'll be, you know, many more reform politicians over the months and years ahead. Of course, it's very changeable, but I just found that a really interesting insight into how it feels like upskilling, working with new councillors.
Yeah. And Sarah, sorry, I just wanted something you said, and that was in the question about neighbourhoods, is really important, because imagine you get elected in these May local elections and you're interested in the hyperlocal, you want to make a difference to this community that you can see. And then the answer is, well, if it's about the NHS, you need to speak to this new commissioning body that now covers a patch that's 4 million people. So you're going to get a political interest at the hyperlocal level, meeting an NHS interest that is just so much bigger. So again, worryingly, you might end up with structures being thrown up once more into the air at some point in the future.
Yes. Right, let's keep going. A question from Alan. What does it actually take to operationalise a shift from sickness to prevention as outlined in the 10-year plan? Siva.
I think it needs two. This is my simple technocratic view. It needs two things. One, you set out some clear measures of how anyone, a health and care select committee, a public accounts committee, us, you, can hold people to account. So basically, what the 5 or 6 things are going to be different if you pull off sickness to or treatment to prevention. Same for the others, analog to digital, and hospital to community. And you know, I'm really sort of interested in the question, because that's one thing the government clearly has not done. It has not said, this is how you judge us on whether the 10-year plan is a success or not, and the indicators we're using. There's some that could lend themselves to it. You know, they were talking about improving healthy life expectancy, halving the gap in healthy life expectancy. Those could be your North Stars. But I think one of the key priorities is come up with a list of measures that give us a clue over whether this plan is working. And the second thing is, unfortunately, I think I've heard people who say, look, that the health service can walk and chew bubblegum at the same time. I do get that. But the second time, I think you have to deprioritize some of the other measures. If you're asking people to choose between delivering something like an 18-week hospital waiting list target and some undefined, broader strategic goal, I know which one is easier to put into an accountability framework and have sharp teeth and you know, oomph behind it. And unfortunately, it's the measures that we have right now. So I think develop the measures and then show you're serious about them by deprioritizing some of the others.
Thank you. And Simon, there's a few questions coming in on a similar-ish theme around how we make sure that we are also interested as a country, as a system, on tackling the social determinants, on using the broader ecosystem of health and care and allied organisations. As a former voluntary and community sector leader, you know, what would you want to see that would help give you confidence that this shift is being taken seriously?
Yeah, I think the point about accountability is well made. I think too, when I was in the voluntary community sector, it always felt as though our role as an organisation was as part of a supply chain, and in order to be part of that supply chain, we had to assimilate into the culture, practices, processes of the NHS as it was when I was in Bristol. So there is something about, for me, what would help with all of these shifts is resisting the pull to standardise it. So what it looks like in central Bristol, where I was, for example, is kind of you can lift and shift that and do it in rural Devon. You know, there's something about decentralising the process of change to the most local level, and having some ways of tying the kind of higher level accountabilities to that. Because to be honest, with these shifts, from an organization development point of view, from a systems change point of view, they're complex problems. So they're going to require iteration, learning, innovation. They're going to require a kind of leadership that allows problem solving to sit very close to the problem rather than at some sort of distant, centralized kind of location. So those are the things I think that would help. And when it just on the voluntary community sector, particularly, a system you sort of learn after a while when you've been in a system. So a lot of the boundaries of the system are really arbitrary. Where we draw the line and we say this is health and that's education, or this is justice and that's health, they're completely arbitrary. People's lives are much more complex and integrated than that. And I think that working with the social determinants, working with the resources in communities and the strengths of communities, and leveraging the proximity of the voluntary community sector to communities and their fleetness of foot, their ability to innovate and take a decision and enact something and try something, those are strengths of the sector and of communities that we ought to be kind of freeing and giving license to, rather than trying to sort of pull into the sort of central orbit of the changes that are described by the plan. I think it was a bit academic, that answer, but
and we are lucky enough at the fund as well to see many examples of brilliant local place-led, community-led work that often is about delivering more preventative services upstream, getting to know people, getting to know what's important to them. So I completely agree with what both of you have said. I'll add two quick things. One is it plays to this point of any system can only have so many priorities, and if you're serious about this prevention shift, you do have to signal it. There are so many things that we'll see this year: a new national cancer plan due next week, modern service frameworks around CVD and other issues. I'll be watching, do they say enough about prevention? And that could be seen as in contradiction to you, Simon. I completely believe in the power of local communities and the local ecosystem driving action, but I also do want a national cancer plan to signal preventing cancers is really important. 40% of cancers are preventable. It should say enough about cancer prevention. And then the macro point is, which we have talked a lot about, and I feel very personally passionately about, the government promised a prevention revolution. They promised this cross-government health mission all about driving improved health in the broadest sense, and so far I think it's fair to say the activity delivered hasn't quite lived up to that. So I'll be watching for those broader cross-government, cross-national signs that prevention is a priority. Next question: what healthcare areas have you seen the biggest tech and AI improvements in recently, and where do you think AI could make the biggest difference next? Simon.
Oh gosh, I don't know. I mean, it's such a big question. And there's a lot of, it sort of depends where you fall on the spectrum of techno-optimism versus sort of skepticism about how this might all play out in the coming years. Where I've seen it, it's been helpful in terms of automating processes that were otherwise quite administratively kind of time consuming. But there's an unintended consequence of that. For example, I was talking to some GPs who have lost medical secretaries who previously were taken out. That relationship, as it turns out, was incredibly important to the well-being actually of the GPs and their connection to their work, their practice. That human connection was a really significant part of what it meant to turn up to work each day. And automating the process might have achieved an efficiency, but there's a loss as well. So I think with this technology, it's very difficult to say where the chips will fall with some of it, and it will really depend on the kind of work that you do. I do think that there is a lot of being invested on the sort of techno-optimism side of this for the future of health and care. And I get why, and I understand why, and I'm probably there myself on my more chipper days. But I think it's also just incredibly uncertain. It was very difficult to know how, and the other thing that's you kind of really notice about AI technologies, they weren't really present in my working life 12 months ago. So the acceleration of these technologies is quite something. When I think about how long it took for the internet to get out of a building that I'd have to go to, or the library, into my home, and then to become something that we know today, that took years and years and years. This technology is rolling out at a rate of knots that makes it very difficult to assess and understand its impact, because then the technology's jumped forward again by another kind of magnitude of 10. So I think it's very, very difficult to say. I see it doing things that are interesting and that pique my interest all the time, but then I'm also very mindful that I also hear things about the unintended consequences of some of those gains, which we weren't cited on.
Yeah, thank you. Siva.
Yeah, I've got to admit, I didn't immediately have an answer of, oh, well, it's going to be these 3 service areas of respiratory, eye care, and yada, yada. You know, when I heard the word area in the question, I thought of California, because the chief sort of technology and strategy officer from one hospital system in California came and did a talk, and she was, I mean, partly it's because she was so cool that I was just lapping up everything she said. But it was things like how technology was laced through everything they did. So things like, I know ambient voice technology, everyone talks about it here now increasingly, but she was really connecting it to, I've given back some time to my clinicians to spend with their kids. That's part of the deal of why we've invested in this technology. But then it was also the clinical impact. So she was saying so many of these medicines that we use are tested in aggregate populations. So we don't know if they really work for an individual, but we are starting to link genomic data, clinical outcome data. So we have a pretty good sense of this blood thinner is probably not going to work for you. This one is. So it's informing clinical decisions. And I just sort of got it. And then the second thing that I'm really enthused about is how technology can change our interaction with services. So again, I saw a local NHS organization that lets you do a virtual appointment for your, you know, say you've got your first ever cancer outpatient appointment. It's come for a virtual tour of what to expect. And you're just taking away that anxiety, a little bit of where do I go? What will happen next? What, you know, all of that uncertainty through something which is a virtual tour that you can fit in if you get any spare time in your day ahead of your appointment. So I'm probably a little bit further ahead on the techno optimism curve than I was this time last year.
Thank you. You thought of California, I thought of Liverpool, and I don't know what that says about our collective horizons. I thought of Liverpool because I had the most uplifting, positive visit to Alderhay Children's Hospital towards the end of last year, and they were particularly showing me ambient voice, the tool that they're using, and what a difference that's making, very much in the context. So I did a simulation with them, but in the context of what it feels like being a patient through their doors, and how it can feel hopefully more personal because you've got the tech working in the background to you know, make your journey smoother. So I mean, I think ambient voice is certainly what I'm seeing most, that's sort of operationalizing. That's one thing I'd say. The second thing I'd say is we're doing some work with health and care leaders, which I think is so interesting, about the leadership challenge of grappling with tech and particularly AI. Simon, it absolutely speaks to this stuff is happening so quickly, you can't possibly keep up, and yet you're being asked to make choices about it. And one of my favourite quotes, I mean, it was Chatham House, but someone said you wouldn't be, this was about a sort of leadership challenge of being asked for an AI strategy. And they said, well, look, you wouldn't be asked for a strategy of for electricity, and yet all my board wants is an AI strategy. And actually AI should be laced through everything. It's a lens, it's a tool, as opposed to, I mean, sort of interesting perspective. So I think the leadership challenge of how you grapple with this across health and care is a very big one. Final thing, I mean, just on a really micro level, what's going to make the most difference to people and patients across our health and care system? I'm watching very closely, as one example, the changes to the NHS app. You know, it is getting better. It is easier to use. I can do things on behalf of my children that I couldn't do a year or so ago. I can see more of my data than I could previously. And I think you ladder that back to Secretary of State's, you know, commitment that we're going to put power in your pocket and really shift the balance between system and patient legislation, and that feels, if we can get it right, notwithstanding the unintended consequences and the potential risk, that feels like a really big prize.
Yeah.
I got quite excited answering that question, and I've lost track of the questions. I knew this would happen. There've been so many fantastic questions coming in. We're nearly out of time. I was holding off on David Buck's question because he's a King's funder, but as ever, he's asked a very good question. What sleeping issue do you think might surprise us this year that could be lurking below the surface, either good, bad, or long shot? Siva.
Oh God. What a fiendish question. I'm gonna knock on wood, because I'm really worried that we are still not resilient enough, prepared enough for something like COVID, or even COVID again. I think, and personally, I've done as much as I can to have personal amnesia for something like it. But my goodness, it doesn't feel, if you're following the COVID-19 inquiry reports, please do, and hearings, hearing those doesn't make me feel like we have much assurance that we're in a much better place. Should something like that happen again. So that's always my sort of sleep. Every time I see something like Mpox, I think it's a sleeping issue, and it's tied to some other issues. So what was it? Yesterday, we lost our measles elimination status as a country. I think so much of our health is predicated on a vaccination approach that was challenged even before some of the wider political forces that might be coming our way. I think that's the thing that is sleeping that worries me.
Thank you, Simon.
Yeah, definitely. My head went to pandemics and COVID a bit as well, because I don't think we ever processed that. And as a workforce, I'm sort of specifically talking about, it's still in there. The moral injury and the fatigue of coming out of that is still very present, but we seem to have sort of dealt with it by suppressing our memories of it. So I would agree with that. So by point of difference, I think the thing that I always am surprised hasn't come up and bitten us more violently yet is one of the things that makes the system tick is the goodwill and discretionary effort of the workforce. If you took that away, either because folk are burnt out or they can earn more or the equivalent in a much less stressful job, I think the whole thing would be really in trouble. And I worry increasingly about how health and care will compete as an employer of the future, and in a future of work, which is also going to be changed massively by AI and some of these forces that we talked about previously. So I don't know whether it'll bite this year, but it feels like it's bubbling away in a really unhelpful way, and it will be interesting to see the staff survey results in the spring, which will come out, won't they, around about the same time as the workforce plan. So yeah, that's one that, and I've spent a lot working with folk earlier in their career as well. You sort of think, why would you come into the health and care system? Would I ever recommend that now to my young daughter as a sort of a career path? I hear lots of medics saying they wouldn't necessarily recommend it. So I think the health and care system and the NHS in particular has a job to do to be that employer that will kind of attract talent and hang on to it. And I worry about that a bit.
Thank you both. I'm going to answer, but I'm just going to give you warning. I'm about to come to you for some final reflections, but I also want to know what you're hopeful about for the coming year. Before I hand back over to you, I don't think I would say this is sleeping, but it's sort of simmering, or it's temporarily delayed as an issue that could explode, and that's social care, because of course we have the Casey review underway, which means that I know Casey and team are obviously working very hard to think through these issues, but it's kind of given political cover to not do that much for a period. And yet we know that too many people are struggling to get access to a decent level of care and support. That's adult and children. We know increasingly local authorities are rationing care, essentially, you know, more people asking for support, fewer receiving it. And I touched on this up front, but I worry particularly about the social care workforce with increased immigration restrictions. Already a workforce that's depleted, that might worsen. And we've often talked about this. There may end up being social care deserts or providers that go under. So I worry that something that's sort of simmering and temporarily got sticking plaster over because a big review's being done could blow up. Final words, Siva.
So final words. First of all, I think whatever happens in health and care will be probably hugely affected, driven by what happens in our national politics. I think this is going to be a big year for our country, and health and social care will be part of that story. I think the second thing, if you follow the unedifying reports about potential cuts to funding for physical education, I think that just emphasizes, picking up some of Chris Branson's point, what one change would make a difference, finding the will to reconstruct this health mission so you don't have the Department for Education and the Department of Health and Social Care potentially knocking umps out of each other, reportedly knocking umps out of each other, rather than saying physical education makes a difference to our health. Why wouldn't we find a way to fund it? And the thing that gives me optimism is, they probably wouldn't describe it as this, but I went, and Sarah, you've heard me talk about this a lot, but I went to a specialist heart hospital where, rather than showing me all the fancy whizzy stuff, they took me into the basement, gave me a finger prick blood test, and within 7 minutes, through an app, I had my cholesterol reading, and after that, I cut down on the booze, the chocolates, went out for a run. So in that one moment, because it's rolled out through pharmacies, you don't have to go to a specialist heart hospital to have that intervention. It is hospital to community, it is treatment to prevention, and it was analog to digital all in one. So I feel like we've got the right plan, we've got the right energy in the right direction. And whenever I see little changes that I can explain to, a person, my mum, I could tell my mum, this is what the health system is doing and it's really good. That's what gives me hope.
Thank you. Simon.
Yeah, the thing that gives me hope is the same thing that worries me in some ways. So, as well as all the things that would concern me about the state of the workforce, there is also a lot. In fact, there's an abundance of kindness, compassion, creativity, goodwill, and that, if you pay attention to it and you dare to kind of notice it, actually is a really hopeful place to kind of spend time and think actually about how we might do more to unlock it. So if we can find some ways through the workforce plan to also focus on the quality of those relations and unlock that abundance of good stuff in teams and in the workforce, then there's every reason to be hopeful, because there is an utter abundance of that stuff.
Thank you. So my final reflection is about the importance of administration for people and patients, and care coordination. We've published on this as a fund. We'll be talking about it more this year. People often say, oh, well, once I got into the system, the care was great, I mainly had a good experience, except, the letter didn't arrive on time. So I really feel very strongly for politicians as well as system leaders. This massively matters to people and patients. Just being able to access and navigate and coordinate, as increasingly we take more responsibility for coordinating our care, improving systems and processes is something we'll be watching, and I think has a direct link to patient satisfaction. And the thing that I'm hopeful about, there's a saying that there's brilliant practice or the absolute gold standard practice happening somewhere every day on every issue in our health and care system, but just not everywhere. And so and we're lucky enough to see some of that wonderful practice at the fund. So I'm hopeful that we can showcase, work with others, make sure that the spread and shared learning continues at pace this year. With that, I have to formally draw the event to a close. So thank you to Simon and Siva, and thank you to the audience for participating. Sorry we didn't get to more of the questions. We'd love to hear what you thought about today's event. You should now have an email in your inbox linking to our feedback survey. If you missed anything or would like to share the link with colleagues, the event will be available to watch on demand on our website. And if you're keen to understand more about the health and care system and its current challenges, please visit our website and sign up for our newsletter and bulletins. Upcoming events also include our annual Leadership and Workforce Summit on the 19th of March. We'd love to see you. And our Health and Care Explained virtual conference on the 17th and 18th of June. We hope to see you at another King's Fund event in the near future. Thank you for joining us. Goodbye.